Hello, everyone. I'm Suchitra Sundaram. I'm an assistant professor in the Division of Hematology Oncology at Mount Sinai Tisch Cancer Institute in New York City. I want to thank the LRF for this opportunity to talk to you all about Burkitt lymphoma. And thank you to all the attendees for taking the time out to attend this session. I also acknowledge that this is a very rare and complex disease, so please feel free to enter any questions you may have in the chat box below. So as a quick outline of what we'll be discussing today, I'm going to give you a quick background of Burkitt lymphoma and background epidemiology of the disease, review the pathogenic drivers of disease. We'll discuss some of the clinical characteristics, staging, and principles of therapy, treatment regimens used in initial therapy, some outcomes in the relapse setting, and novel agents and future developments in this area. So lymphomas, as we know, are cancers of the lymphatic system or the immune system, largely classified as non-Hodgkin and Hodgkin lymphoma. 70% of the lymphomas are non-Hodgkin, while 30% of them are Hodgkin lymphoma. Burkitt lymphoma is a very rare but aggressive disease comprising of only 1 to 2% of all non-Hodgkin lymphoma in adults. In the United States, around 1,200 cases of Burkitt lymphoma are diagnosed each year. In children, this is more common and comprises around 30% of the childhood non-Hodgkin lymphomas. So Burkitt is a highly aggressive form of mature B-cell lymphoma, which is a cancer of the lymphatic system, as we know, but specifically the B lymphocytes that are found in the germinal center of the lymph nodes. So this was reported in 1956 by a surgeon, Dr. Dennis Burkitt, among children in Africa, where children presented with rapidly progressive, unusual tumors of the jaw, which were later identified as lymphoma. Soon it was shown that the Epstein-Barr virus, also called EBV, was associated with almost 100% of the Burkitt lymphoma patients and contributed to the development of the African Burkitt lymphoma variant. Since this description, it's been recognized that Burkitt lymphoma can occur even outside of Africa and in both pediatric and adult populations, as we will see in the next slides. It typically affects younger patients. In fact, it's the most common type of pediatric non-Hodgkin lymphoma. However, it may be also seen in elderly patients as well, and is seen more commonly in males than females. There are three major types of Burkitt lymphoma: the endemic variant, the sporadic variant, and the immunodeficiency-associated Burkitt lymphoma. Endemic Burkitt is commonly found in children in specific malaria endemic geographic regions, such as Africa and regions of South America, where this is the most common childhood cancer. It affects males between the ages of 4 to 7 years, and it's very strongly associated with infection with the EBV virus. Children here present with tumors in the facial bones and other parts of the skeletal system and the central nervous system. Outside of Africa, Burkitt lymphoma is rare. Sporadic forms occur in children and adults worldwide, including the US and parts of Europe, less commonly now associated with the EBV infection. And the third variant is the immunodeficiency-associated Burkitt lymphoma, which is commonly found in found in patients with HIV, those who have also undergone an organ transplant and take immunosuppressive medications, and also those with inherited immune deficiency syndromes. In fact, before the availability of the highly active antiretroviral therapy for treatment of HIV, the incidence of Burkitt lymphoma was associated and estimated to be at least 1,000 times higher in HIV-positive patients than in general population. So Burkitt lymphoma was the first lymphoma, in fact, in which a genetic alteration called a chromosomal translocation was linked to the development of the cancer. This defining genetic hallmark we're talking about is something called the reciprocal translocation of the MYC gene, located on chromosome number 8 to chromosome number 14, which is an important finding in the diagnosis of the disease. So this places the MYC gene under the control of the IgH, or the immunoglobulin heavy chain gene, on chromosome number 14, as we can see. And what happens because of this is that there's an activation of the MYC gene, an amplification of sorts, which leads to uncontrolled growth and division of cells. So here's what a biopsy of a Burkitt lymphoma tumor would look like. So we commonly see a complete takeover of the lymph node architecture by sheets and sheets of peculiar looking cells called lymphocytes, which are usually intermediate in size, and they have an extremely high growth fraction called Ki67. So this growth fraction is as high as 100% in patients with Burkitt lymphoma. And some of the lymphoma cells, they have an abundance of these white vacuoles we see here, and sort of giving it a starry sky appearance, which is also a classic finding. But pathological diagnosis sometimes can be challenging. In adults, specifically Burkitt lymphoma, sometimes difficult to distinguish from diffuse large B-cell lymphoma, which is a more common form of aggressive mature B-cell lymphoma. So accurately distinguishing Burkitt lymphoma from diffuse large B-cell lymphoma is critical because every disease is treated differently. Hence, patients with suspected Burkitt lymphoma should, when possible, undergo an excisional biopsy. And it's also crucial to have access to an expert hematopathologist experienced in diagnosing lymphomas to arrive at an accurate diagnosis. So this is one of the most aggressive forms of lymphoma. And what happens when patients present with these tumors there's a classic presentation with rapidly enlarging lymph nodes in the neck, in the armpit, in the abdomen, jaw. But this can really involve any organ, causing rapid organ dysfunctions. Another symptom that's very common with these types of lymphomas are the characteristic B symptoms, which are these drenching night sweats. So patients may have to change their sheets and their clothes. And they also endorse unexplained significant weight loss, and there's also loss of appetite. This lymphoma also has a high tendency to involve the central nervous system, and as high as 40% of the cases at diagnosis can have an involvement of the leptomeningeal system. Accordingly, patients may present with mental status changes and visual changes. Symptoms of spinal cord compression, such as limb weakness or paraplegia, can also be found. Because of high rates of cell division and turnover, especially in patients with advanced stage and bulky disease, patients can present with an entity called tumor lysis syndrome, which occurs as a result of breakdown of the cancer cell, release of the contents into the blood, presenting as high blood levels of uric acid, high levels of other electrolytes like phosphorus and potassium, and low calcium levels. So tumor lysis syndrome, when present, should be considered as a medical emergency, given that there's a potential for rapid progression to life-threatening complications, including renal failure, cardiac arrhythmias, and sometimes even seizure. So when detected, we commonly admit patients to the hospital immediately to start treatment for this. In short, what we can see here is that the clinical course of Burkitt lymphoma is rather aggressive. So timely diagnosis and urgent treatment is absolutely crucial in this cancer, without which sometimes this lymphoma can be highly fatal. So to determine a stage in Burkitt lymphoma, we use the same staging system as another non-Hodgkin lymphoma, wherein stage 1 is disease localized to a single lymph node or a single organ. Stage 2 involves 2 or more lymph node regions on the same side of the diaphragm. Stage 3 is involvement of the lymph node regions above and below the diaphragm. And stage 4 is when there's widespread involvement of organs, including the brain system, with or without lymph node involvement. Burkitt lymphoma patients commonly present with more advanced stages of disease, although they can also have early stage disease. So here are some of the steps we use in evaluating the disease. We do a thorough history taking, assessing the rapidity of growth of tumors, specific symptoms that may be related to the tumor growth, whether it's organ involvement, organ compression, compression of the kidneys, for example. We evaluate for B symptoms. We also assess the physical fitness of the patient, what we call the performance status, and look for underlying other medical conditions that may need to be considered while planning therapy. We perform a thorough physical examination, looking for lymph nodes or other swelling in the body. Typically, in terms of imaging, we get a CT scan or try to get a PET scan when possible. We have a low threshold to perform an MRI of the brain, especially if patients present with symptoms of nervous system involvement. We also perform some blood tests, including markers of tumor lysis. Bone marrow evaluation is often performed, as over 70% of the cases of Burkitt lymphoma can have presence of bone marrow disease. Cardiac testing prior to intensive chemotherapy is performed, and evaluation of the spinal fluid that layers the brain, and is also something called a lumbar puncture to look for presence of lymphoma cells. So needless to say, given the aggressiveness of the disease and the benefit of prompt initiation of therapy, these steps in diagnostic evaluations should really be expedited when Burkitt lymphoma is suspected. So once we have the diagnosis confirmed and the staging evaluations are confirmed, it's vital to start therapy immediately. At our institution, we aim to initiate therapy within 24 to 48 hours of suspecting Burkitt lymphoma. What's peculiar about Burkitt is that it's a highly curable disease, and the cancer is actually extremely sensitive to chemotherapy. So as long as the appropriate treatment is executed expertly and expeditiously, the general belief is that the patients should be cured. These treatments can be complex and can involve intensive multi-agent combination chemotherapy. So these patients should be ideally treated at centers equipped with expertise and the supportive care services needed to manage the toxicities or potential toxicities of the treatments. Hence, it's common for patients with Burkitt lymphoma to be referred to a tertiary care center equipped with some of these services. Due to the high risk of involvement of the brain and the spinal system, it's important to involve or incorporate agents in the chemotherapy that actually penetrate the blood-brain barrier, even if it's a preventative measure in order to attack any potential lymphoma cells in the nervous system. Also, as these tumors are so sensitive to chemotherapy, it's important to know that there is limited role for radiation in our treatments, and this is the case even if the disease is localized to a single site. So while choosing the initial therapy for Burkitt lymphoma, we take into account several factors such as the age of the patient, presence of other medical conditions, as an example, kidney function abnormalities or heart disease. We take into account and assess their performance status, the disease stage, any evidence of involvement of the brain system, the risk level of Burkitt lymphoma, such as the bulk of the tumor or the size of the mass, the blood LDH levels, which is a marker in the blood of aggressiveness of the lymphoma generally at diagnosis, and if the patient has evidence of spontaneous tumor lysis syndrome at diagnosis before they start chemotherapy. Since Burkitt lymphoma is a rare disease compared to other aggressive lymphomas, such as diffuse large B-cell lymphoma, there aren't, unfortunately, many randomized clinical trials comparing different treatment regimens head-to-head. Hence, picking the appropriate therapy can sometimes be pretty challenging, particularly in middle-aged and older adults in whom toxicity actually poses significant concerns. So the current standard of care today are short courses of aggressive chemotherapy regimen in combination with an anti-CD20 antibody, monoclonal antibody called rituximab. So we also include therapies here directed at eradicating or even preventing CNS disease. A risk-adapted strategy, considering the various clinical factors that were shown in the previous slide, can be helpful in guiding therapy decision-making when picking like the initial first-line therapy, especially. For example, less intensive regimens may be useful in patients with low-risk Burkitt lymphoma or those who are not fit for intensive chemotherapeutic approaches. It's important to consider the risks of precipitating tumor lysis syndrome as the treatment is initiated and being prepared with the necessary supportive management team and measures to manage this emergency. So with this background, I will discuss some of the common therapeutic regimens used in this disease. So one of the first regimens studied in Burkitt lymphoma was in 1996 by Dr. McGrath and his colleagues at the NCI. So this was called the CODOX-M IVAC. It's a combination of the various regimens that are shown here, given in alternate cycles. The number of treatment cycles and the specific drugs involved were determined by the risk category for the disease. So patients were considered low risk if they had a single site of disease, less than 10 centimeters in size, and with a normal blood LDH. And all of the patients were considered high risk. So patients with low risk received 3 cycles of CODOX-M alone, and those with high risk received 2 courses of alternating CODOX-M and the IVAC regimen. It's important to note that the median age of the patients on this clinical study was only 25 years. So in this young group, they actually noted fantastic responses in this trial, and with a 2-year event-free survival rate of 92%. So event-free survival, it's important to know, is the measure of time after treatment that a group of people in a clinical trial have not had their cancer come back or haven't gotten worse. So this 2-year event-free survival was actually 100% in adult patients on this study. However, it's important to know that there were severe toxicities, mainly significant suppression of the bone marrow, affecting production of the blood cells. So low blood counts and resulting high rates of infection were noted. So subsequently, this CODOX-M IVAC regimen was studied in older adults, and not surprisingly, the results were less favorable, mainly because a sizable number of patients, which is around up to 20% of the patients, actually could not even complete therapy due to severe toxicities with this regimen. Hence, a modification to the CODOX-M IVAC was attempted with a hope to reduce toxicity. So they decreased the doses of the drugs methotrexate and cytarabine, which are components of this regimen. And this modified McGrath regimen now was tested in a population actually even slightly older than the original study, so a median age of around 35 years. And here we can see the 2-year progression-free survival for all comers was around 55%. And what was interesting is that patients with low-risk disease were disease-free at the 2-year mark. 85% of those patients were disease-free at the 2-year mark, but around half of the patients with high-risk disease had progression of the disease by the 2-year mark. So as we can see here, especially for the high-risk subgroup, these cure rates are substantially lesser than the initial McGrath publication, but still much better than historic data with standard dose regimens. So this approach is still endorsed as a reasonable one for the majority of adult patients with Burkitt lymphoma today. So Burkitt is actually biologically very similar to a type of aggressive leukemia called acute lymphoblastic leukemia. So a regimen commonly used to treat that entity was modified for use in adults with Burkitt lymphoma, and this is the hyper CVAD MA regimen. So this was developed at the MD Anderson Cancer Center and comprises of multiple agents such as hyperfractionated cyclophosphamide, vincristine, adriamycin, and dexamethasone, alternating with high-dose methotrexate and cytarabine. In a study of 26 patients treated with this regimen, modest 3-year overall survival of 49% was achieved. So in the study, what we see is there was high mortality associated with treatment, as high as 20%. Specifically, this was a challenge in older adults where the survival with this regimen here, as we see here, is abysmal here. Subsequently, the group then added rituximab to this regimen and treated now a large number of older patients as well. So median age on this new trial was around 46 years. And the results were actually significantly better, with overall survival at 3 years of around 89%. And of these, interestingly, 30% of patients were older than 60 years. So this group, what we saw in the trial was they had an equivalent overall survival to younger patients. So it's really unclear why the results were this fantastic in this age group in this particular study, whether the observed outcomes, improved outcomes, were directly related to the addition of rituximab, were there refined diagnostic criteria, was there increased experience with the regimen, or maybe supportive care was even better with this particular trial. It's unknown. In current practice, we do often use this regimen, and there are severe toxicities still encountered. Mainly bone marrow suppression is commonly seen. Hence, it's important to select the appropriate patients, perhaps younger, fit patients with low comorbidities who may be able to tolerate this regimen better. In an attempt to preserve efficacy of the treatment while reducing toxicity, the National Cancer Institute designed a regimen called dose-adjusted R-EPOCH, which is a combination of these agents given as a continuous infusion. So this regimen can be safely given in the outpatient setting as well, which makes it a pretty attractive choice for several patients. Central nervous system prophylaxis was achieved by incorporation of intrathecal or spinal chemotherapy, methotrexate. The study also included a substantial number of patients with HIV. Patients were again stratified by risk, so patients with low risk receiving as little as 3 cycles of R-EPOCH, while those with high-risk disease received all 6 cycles of R-EPOCH, as well as spinal chemotherapy for CNS prophylaxis. And with a median follow-up of around 4.5 years, what we saw is dose-adjusted EPOCH achieved a freedom from progression of 82% and overall survival of 87%. The rates of severe infections were also low as compared to other regimens. However, patients with CNS disease and those with bone marrow involvement with Burkitt lymphoma did less well as predicted, with cure rates only around 60%. So the results here, nevertheless, are quite convincing that dose-adjusted EPOCH is quite high or highly efficacious in Burkitt lymphoma. And there's no question that this regimen is easier to deliver than the traditional regimens we discussed before. One of the reasons being the outpatient administration being an option itself. And this is particularly useful in older adults who tend to tolerate this regimen much better with less toxicities. And in those patients, it can actually be considered the standard treatment, with the more traditional intensive options reserved for patients with bone marrow involvement or CNS involvement, as those are clearly high-risk features in this disease. The other regimens studied were the CALGB regimen, or Cancer and Leukemia Group B. They published a trial of intensive short-duration chemotherapy that enrolled patients with a median age of 47. So this is perhaps the highest median age of any trial incorporating an intensive regimen for this disease. So in the study, only approximately half of the patients were cured of disease. And unfortunately, there were also severe neurological toxicities such as transverse myelitis, neuropathies, and even blindness. So adjustments had to be made to the CNS prophylactic regimens, which then improved tolerability to this regimen. In Europe, another pediatric regimen that was used to treat acute lymphoblastic leukemia was then adapted to treat adults with Burkitt lymphoma. So this French LMB group studied this combination chemotherapy of vincristine, cyclophosphamide, and doxorubicin in low and high-risk patients. Again, low-risk patients receiving fewer cycles, high-risk patients receiving additional cycles of therapy, as well as addition of the CNS penetrating drugs. And what we see here is the 2-year event-free and overall survival were 65 and 70% respectively, which is pretty favorable overall. So while there are several such intensive therapeutic regimens individually studied, given the rarity of the disease, very few of these studies have had large enough patients to be able to adequately compare the therapeutic regimens and to examine the potential impact of these regimens on outcomes. Also, it was unknown what were the factors that may determine prognosis at the time of diagnosis and predict survival from Burkitt lymphoma. So this is where some real-world outcomes data initially have actually shown some interesting findings I would like to review here. So Dr. Evans and colleagues presented this multi-centric retrospective analysis of 600 patients with Burkitt lymphoma with data contributed by 30 US cancer centers. And this is by far the largest report of real-world experience of Burkitt lymphoma to date. So they analyzed treatment patterns, influence of disease-related factors, and their impact on patient outcomes. They also identified factors determining prognosis and survival rates with the regimens that are actually used in modern era. So some of the key findings of this report are that the survival of Burkitt lymphoma in the real-world scenario outside of clinical trials were actually modest as compared to what we were seeing in clinical trials data so far. the 3-year overall survival, even with the intensive therapies, were just about 70%. So this is often seen and is the case with very aggressive cancers like Burkitt lymphoma, as these patients are either too sick to be enrolled on clinical trials, or they may need immediate start of therapy as soon as they are diagnosed, and they cannot really wait through the screening procedures and the investigations needed to enroll onto a clinical trial. Next, what we see in this study is that the 3 most common chemo regimens we've discussed, the CODOX-M IVAC, the hyper-CVAD, and the dose-adjusted R-EPOCH, all had overall similar outcomes with respect to survival. Treatment-related mortality rate was still significantly high, and it was seen across most regimens, and this was especially prominent in older adults, as would be expected. Importantly, there was a lack of survival difference between HIV positive and HIV negative Burkitt lymphoma. And finally, the researchers identified several factors that were associated with worse outcomes with the disease. And some of those adverse prognostic factors were age at diagnosis more than 40 years, and elevated blood LDH level more than 3 times the upper limit of normal, poor performance status, and presence of central nervous system involvement at diagnosis. So if the patients had absence of any of these 4 prognostic factors, this would be delineating a group of Burkitt lymphoma patients with progression-free survival rates that exceeded 90%. Conversely, the higher risk group, which had 2 or more of these adverse factors, which is usually over half of the Burkitt lymphoma patients we see in the real world, had much poorer survival. So these factors, it's important that they be considered in clinical practice to help decide on treatment strategies. And overall, we learned that there's a continued need to identify the optimum treatment of Burkitt lymphoma with high-risk disease specifically, and those with CNS disease. It's also important, though, to identify the patients with low-risk disease, where maybe lower amount of therapy may be sufficient to achieve a cure in these patients. So a quick note about treatment considerations in the older adult. Here, it's important that the therapeutic efficacy be carefully balanced against potential toxicities, particularly in those with underlying comorbidities. So in this real-world analysis, we observed that treatment-related mortality was higher, in fact, with hyper-CVAD as compared to CODOX-M IVAC and dose-adjusted EPOCH, especially in this older population. So finally, since we see regimens and outcomes with these infusional regimens, such as infusional dose-adjusted R-EPOCH, being so favorable and potentially also with less toxicity as compared to other regimens, and also that a regimen like dose-adjusted EPOCH has been studied in a sizable number of older patients. So this may be a preferred option in this age group of patients. Treatment of patients who have relapsed and refractory disease, though, after initial therapy for Burkitt lymphoma is actually a substantial challenge in need of attention. Despite the high cure rate that we see in Burkitt lymphoma in the frontline setting, unfortunately, patients who are refractory to the initial treatment have very poor prognosis. In a recent study, we've observed that the median overall survival was only 3 months or so. And one of the difficulties in treating this group of patients is just the aggressiveness of the disease when it relapses and how rapidly it progresses. And secondly, the rarity of the disease that makes it challenging to conduct clinical trials. And in fact, Burkitt lymphoma sometimes has often been excluded from clinical trials of other aggressive lymphomas. So at the current time, when we have a patient with relapsed refractory disease, we typically use second-line chemotherapy when possible, using chemotherapeutic regimens that the patient's not been previously exposed to when possible. And in those achieving a remission, we consider a transplant. So this could either be an autologous stem cell transplant using healthy stem cells from the patient's own body to replace their damaged or diseased bone marrow, or an allogeneic transplant, which involves transferring the stem cells from a healthy donor to the patient after intensive chemotherapy. However, what we've seen is from limited literature in this area, it appears that transplants in this setting have always not been able to control the disease in the long term. And there are also sometimes some severe side effects, specifically with the allogenic stem cell transplants. So clearly, future research is needed in this disease. We need to better understand the biology of the disease and to maybe even continue to identify other molecular aberrations that, other than MYC, that are ongoing and Burkitt lymphoma pathogenesis. And this may then pave way for maybe the development of novel therapies. So participation in the clinical trial, when available, will be highly and is highly encouraged in this disease. So along those lines, some of the novel approaches in Burkitt lymphoma I just wanted to kind of highlight. And some of the ongoing clinical trials we see are investigating various combinations of these novel agents in combination with the agents we already mentioned in the previous slides. And these novel agents are also being investigated alone or as a part of combination of novel agents in relapsed refractory disease. So first one among these that we're looking forward to are the CD19-directed chimeric antigen receptor T-cell therapy, or popularly known as CAR T-cell therapy, as well as bispecific antibodies, which is another form of immunotherapy. These have been pretty effective against acute lymphoblastic leukemia and diffuse large B-cell lymphoma, where we've observed some very promising results. So they are in clinical trials, and we're hoping to see in the future some data in Burkitt lymphoma as well. Some other agents that we've seen are demivistat, which is CPI-613 that disrupts mitochondrial function and targets enzymes that are involved in cancer cell energy metabolism. Nivolumab, which is an immunotherapy that harnesses the immune system to fight cancers, in combination with lenalidomide, which is an immunomodulating drug. Ofatumumab, which is a fully human monoclonal antibody to CD20, in combination with dose-adjusted R-EPOCH that we've seen before in the frontline setting. Then there's obinutuzumab, which is a second-generation glycoengineered monoclonal antibody in combination with ICE as a standard salvage treatment in aggressive lymphomas. Venetoclax, that causes cancer cell death or apoptosis. This is being used in combination with ibrutinib, which is a BTK enzyme inhibitor, in combination then with obinutuzumab and lenalidomide. Another one is acalabrutinib, which is also a BTK enzyme inhibitor, with pembrolizumab, which is an immunotherapy or a checkpoint inhibiting drug. So future down the line, perhaps inhibition of targets such as PI3 kinase, cyclin-dependent kinases, and MYC would be rational strategies that could be considered for future development of drugs. So in summary, Burkitt lymphoma is a highly aggressive non-Hodgkin lymphoma that requires expert hematopathological diagnosis. It's important that there is rapid incorporation of multi-agent cytotoxic chemotherapy, and that may be a key to a successful outcome in this disease. It's important to also remember that a vast majority of patients are cured. However, outcomes are less favorable in patients older than 60 years of age. And these patients are also not well represented in clinical trials and do not tolerate the very high intensity regimens well. So hence risk-adapted approaches should really, when possible, guide therapy decision making in this setting. So less intensive regimens for older adults with medical comorbidities and poor performance status, while some of the more aggressive regimens may be restricted to younger patients who may have who may need CNS-directed therapy as well. Patients with relapsed refractory disease should be referred for participation in clinical trials with novel agents when available. And finally, clinical trials that incorporate these novel agents into even the upfront strategy in Burkitt regimens, they offer the possibility of these curative strategies with less reliance on some of these toxic agents. So there's some resources I just wanted to add to these slides here. So the LRF offers a wide range of free lymphoma disease-specific booklets and these fact sheets for patients with lymphoma and their loved ones. So here's one for Burkitt lymphoma. And in addition, the LRF website also has disease-specific survivorship fact sheets for patients in remission from their disease. These have been incredibly useful. I've actually reviewed some of these fact sheets and have distributed it to my patients, and they've found it extremely valuable and informative. And I'll end here. Thank you all for your time and attention, and I hope this was useful. My contact info is posted on your screens here, and I'm happy to now take any questions via the chat box. Thank you so much.